I am particularly glad to be here today to present the data of this phase 2-3 multi-center trial which was conducted both in Europe and in the US for addressing what really represent an unmet medical need, namely the treatment of patients with primary HLH. Primary hemophagocytic lymphocytosis is a rare disorder characterized by hyperinflammation. It has been estimated to occur in around 1 newborn and 50,000, and it is characterized by severe clinical signs and symptoms, which, if not promptly recognized and timely treated, can even lead to the death of patients. And these symptoms include prolonged fever, splenomegaly, and in general also hepatomegaly, profound cytopenia, hyperferritinemia, and hypercytokinemia. Available conventional therapy for primary HLH have mainly two goals. Initially, to dampen the hyperinflammation which characterizes this disease, and the Histiocyte Society launched in 1994 the first multi-center trial for treating patients with a combination of steroids and etoposide. This led to a significant improvement in the probability of survival of these children in comparison to the few initial reports on this disease, but you can certainly agree with me that there was room for improving because the long-term outcome show a probability of overall survival only in the order of 54%. The addition of cyclosporin A with the scope of modulating the T-cell hyperactivation didn't result into significant improvement. And there are no standardized therapy for those patients who fail frontline treatment, although alemtuzumab, an anti-CD52 monoclonal antibody, has been reported to be effective in some retrospective analysis. And in general, the chemoimmunotherapy that I was mentioning before results in profound immune suppression, and when patients are given etoposide, also in myelosuppression. And this precludes significantly a good chance to be cured by the only available curative treatment, which is represented by allogeneic stem cell transplantation. Indeed, most patients with primary HLH have defects in gene known to regulate the trafficking, docking, fusion and release of cytotoxic granules of both T lymphocytes and NK cells. Several clinical and experimental data suggest that the key cytokine playing the major role in the pathophysiology of primary HLH is interferon gamma. Indeed, elevated patients of interferon gamma can be found in patients with primary HLH, and in a mice model of HLH characterized by biallelic mutation of perforin, which is one of the genes known to cause HLH and children, demonstrated a significant improvement in the probability of survival of these mice. So all this data led to the development of an anti-interferon gamma monoclonal antibody for treating this patient. The monoclonal antibody is called Emapalumab, and in this cartoon you can appreciate how the monoclonal antibody works. Indeed, it is a fully human IgG1 able to recognize both free interferon gamma and interferon gamma bound to its receptor. And the use of this monoclonal antibody impairs the dimerization of the interferon gamma receptors, this blocking the cascade of the event activated by the hyperproduction of interferon gamma. The trial that I will present both today in the FDA meeting and tomorrow morning in the late-breaking abstract session was conducted in 9 European centers and 6 US centers. I like to acknowledge the role of my co-PI in US, namely Dr. Jordan from Cincinnati. The aim of the study was that of evaluating how the neutralization of interferon gamma can impact on the course of this disease, and we treated both patients who failed previous therapy. They were indeed the majority, 27 out of the 34 treated patients, or even patients who were naive of any treatment, 7 additional patients. This is the study design. The treatment duration was at least 4 weeks up to 8 weeks, and patients at the end of this treatment can either continue the monoclonal antibody till allogeneic stem cell transplantation for those patients who carry the genetic defect known to cause HLH, or can discontinue treatment and enter into the long-term follow-up study. The monoclonal antibody was initially administered at the dose of 1 milligram per kg twice a week, and in case of not perfect control of the disease, it could be increased up to 3, 6, and in one patient 10 milligram per kg. These patients also were given simultaneously dexamethasone at the dosage of 5 to 10 milligram, which could be tapered according to the assessment of the treating physician. Since around 1/3 of children with primary HLH have CNS involvement, intrathecal therapy was also recommended. As I mentioned before, we included overall 34 patients, 27 were treated with the drug in second line. Median age was around 1 year, with an equal distribution between males and females. And you can see that around 80% of all these patients carried a BL-NEC mutation of gene responsible for HLH, including perforin or MUNC or syntaxin binding protein. The primary efficacy point of the study was the overall response rate, and we found that both in the whole population of patients and in children treated as second line, the overall response rate was significantly higher than the pre-specified null hypothesis of 40%. And also the investigator assessment confirmed exactly this data. This clearly demonstrating that the drug is able to control the hyperinflammation driven by interferon gamma. Secondary efficacy endpoint were the median time to overall response, which was indeed very fast, because it was 8 days in both study population. This meaning that after the second dose of the monoclonal antibody, these patients reach their response. And the median cumulative duration of response until the start of conditioning regimen for transplantation was in the order of 5 weeks for both patients who had failed previous therapy and also in patient treated as frontline. And patients overall were in response for a median of 75 days during treatment. In terms of safety and tolerability, of course, this being a population of children very fragile, it's not surprising that several adverse events were recorded, but a serious adverse event were recorded in half of the patients, but only in one of the 34 patients, it led to treatment discontinuation. So in view of these results, on November 20, FDA approved Emapalumab as a first agent for patients, both adults and children, newborns and olders, with primary HLH refractory to the treatment or relapsing after the treatment or not fully responding to the other agents or intolerant to the therapy. So I will be more than happy to take any other question. Thank you.